I think we rather. I think we're rather start.
Yes, I'm launching the YouTube channel right now.
It's already there, so.
Please, can you
mute our microphones?
I bet you I'm going to, yes, put off your microphones. I bet you I'm going to share this with you.
Okay. Okay, so you want me to put that on the main channel?
Yes, please.
Okay.
Okay, Ben, can you do the slideshow?
All right. Thank you, friends and classmates and colleagues.
I thought we should have done some small intro. This is the first time we're doing such, and I think that before you dive into your presentation, we should try and let people know some rules, some basic rules. That is to say that we have a host and co-host, and we have a presenter. The presenter is the main person that is giving us the talk this evening. And at the end of his presentation, there's going to be a discussion, question and answer session. And please, we'll try as much as possible to give everybody a chance to ask their question and to express themselves, but we have to do that orderly. And we are supposed to also make sure that our microphones are mute when one person is talking, so that there is no cross-talking and we can hear each other clearly. I'm very pleased that this is happening. We thought it couldn't, but here we are today. It's happening, and I think this is very positive for our mates. We are all showcasing what we left school and did after CAS Bambili. And I pray that this talk helps one or two people, not only us as classmates, even our loved ones. We should be able to share this information with them and see how well we integrate, all of these talks into our daily lives and to better our health. This is not the first and the last talk. This is just the beginning. We're going to have many more talks on many more things, but we thought that health first because we are not growing younger, and that we should take care of ourselves and make sure that we are alive, then we can talk. So thank you very much, Dr. Fu, for accepting to do this first talk. I want to tell mates that you willingly accepted, and this is very good for us. So I leave the floor to you, and we'll only listen and follow what you have to tell us. Thank you very much. If any other person has something to add, please go ahead before he starts.
Thank you, John, and thanks for your tireless leadership of making sure that we have something like this. I will just give a little warning. Sometimes I can talk a lot. The way I structured the slide was such that I shouldn't take too much time talking, so we'll have more time discussing. A topic like this is important to all of us. I think even as a medical professional, I do not know how I would tell you that when I sit down with families, I learn from them, they learn from me. Cancer care is a collaborative discussion. You may have the scientific facts, you may have some of the data, but it's all inclusive. It takes a lot of the emotional aspects and the family support in this. Another disclosure upfront, I have been told that when I speak, I tend to eat my words at the end of my sentences. That's something I'm aware of, so I try to counter that. So you see me try to be very intentional towards the end of my sentences. However, if I say something and people don't understand what they say, I say just feel free to remind me of that. You can just unmute and say you are sliding off. I will just go ahead and start up front here with some objectives. In my opinion, I thought today we will get some basic data on cancer. We have a very heterogeneous audience. The only thing common amongst us is that we went to Cass Banbury and we are middle-aged and we are interested in discussing this, but we come from different professions with different levels of health literacy. So I hope that I will strike a balance as we go through that. So a little bit of basic data on worldwide cancer and cancer in Cameroon. I will outline some strategies of diagnosis, especially early diagnosis and management. Again, we are not talking about a medical student or resident lecturer on cancer care. We'll talk about preventative strategies. Those are actually very critical. And then I hope to, based on this, elicit audience comments, and then we can answer questions. You may answer my question, I answered yours, or somebody answer other person's questions. I'd like to make some few disclosure. Again, I'm speaking here just as Beng Fu, classmate of S2 1990 class, who is now about 32 years older. I do not speak on behalf of East Carolina University or Vidant Medical Center, my employers. I have served on multiple advisory consultative boards of biomedical and pharmaceutical companies, but I am not pushing any product. I'm not trying to discourage any product either. So I hope the talk will be free of commercial bias. I am licensed to practice medicine only in the United States. I am not licensed to practice in Cameroon or anywhere else in the world. And this is an informational talk, and it's not supposed to be a medical consultation for anybody. If you need that, you should consult your medical provider. So I just wanted, before we go in, I know this slide looks a little busy, to talk a little bit about what is cancer. As we learned in biology in secondary and high school, our cells have to renew all the time. We have trillions of cells, they renew. The interesting thing is that they are very well laid out principles through which cells renew so they can respect their boundaries. Cancer happens when some of these cells develop the ability not to follow the laid down rules of cell division. And then cells are supposed to stick to the organs that they belong to. Cancer cells do not follow any of those rules. So not only do they take up space within the organs they are in, but they will invade other organs and they may spread to other organs. Again, normal cells, they will die all the time, they will be replaced. There is a very organized process called programmed cell death. Cancer cells do not. But when you have this orderly process break down and you have cancer cells grow without respecting the rules, they first form tumors. There's a difference between tumors and cancers in general. All cancers you can say are tumors, but not all tumors are cancers. So you can find a tumor that grows, but it respects the rules, it stays within one organ, it takes up space, it doesn't invade into neighboring tissues. So we call those benign tumors or non-cancerous tumors, as opposed to the cancerous tumors, which are the ones that just act crazy. So what is the burden of cancer? It's not just because I'm a cancer doctor that I want to make cancer important. Cancer is a leading cause of death worldwide. So if you look, there are about 18 million people who will be diagnosed with cancer every year, and of those, more than 9 million will die. It is a rapidly increasing problem, and cancer is supposed incidence will double by 2050. Now, cancer is generally nowadays more common in the advanced economies, with some exceptions. There are some cancers, including cervical cancer, that's more common in less advanced economies. But the key reason is that cancer risk increases with age, and life expectancy is just higher in the developed economies than in less developed economies, and that is the key reason why you have cancer most common in the advanced economies. The most common type of cancer in the world is breast cancer. This is followed by lung cancer, then prostate cancer, then colorectal, then skin cancer. So this is data for the whole world. When we look at cancer burden in Cameroon, which is our home, and where most of our loved ones will be, most of our peers will be too, there is very unreliable data on cancer in Cameroon. That's because Cameroon is principally preoccupied with other health challenges, and cancer is not the #1 challenge that they are dealing with. Despite this unreliable data, we know that the incidence or the rate of cancer happening in Cameroon has been increasing very rapidly. The latest data we have is from 2020, where they report that about 15,700 cases were found in Cameroon. Of those, about 1/3 died. The most common cancers in Cameroon, just like the rest of the world, is breast cancer, but it's followed by cervical cancer, and then prostate cancer, liver cancer, and colorectal. And we will talk about this in a little bit. So the government of Cameroon has a strategic plan. They say Plan 2020 to 2024. This is funded in part by the World Health Organization, the International Atomic Energy Agency, and many others. But this so far is mostly in paper. There are still some challenges. Since we are not having a health policy talk, I'm not going to go deep into that. But just to give some background to that, if you just look at the rates of cancer, you will see that cancer has increased steadily in Cameroon. You go back to the 1980s, has increased steadily. If you look at the distribution by cases, you will see that men and women have cancer. But let's just move to the slide, which is quite interesting here. So you will see the vast majority of cancers are unknown. Here are others, but breast cancer takes up almost 20% of the cancers in Cameroon. You see cervical cancer here. So that's pretty significant. Another slide I just wanted people to take a look at. Again, this comes from the government cancer data. Is because Bramley being in the Northwest region, if you look at the Northwest region, it would appear the Northwest region has the highest number of cancer. When I reviewed this, it was very interesting to me. One, because when I was a student in Germany, I got in contact with the GTZ, who was working back then with in Cameroon, and the Northwest was their pilot to look at how do you gather health statistics. So the Northwest, it happens, had the best data that you have in Cameroon when it comes to cancer data. So you see that on almost all types of cancer, where you're looking at breast cancer here, or you're looking at cervical cancer, or you're looking at prostate cancer, the Northwest has about 3 to 4 times higher incidence of cancer. And the Northwest is not the most populous region in Cameroon. What this tells me is that if you had good data in Cameroon, all of these numbers we are seeing here will be way up here. So they have been diagnosed and recorded here. That's why we are seeing them. All of these that are not being diagnosed. That's why the numbers look as low as they look. So the cancer burden in Cameroon is a lot higher than what the government knows or what the medical community knows. So I wanted to try to go into what I think is more interesting for us. So what are some of the risk factors for cancer? We are going to talk in general, but some of these have made them more specific to Cameroon. Infections are actually one of the #1 risk factor for cancer in Cameroon, and we'll go into this in a little bit. The immunodeficiency. So one thing that people don't talk a lot about, the key thing that protects us from cancer is our immune system. That is why we call immune surveillance, which goes around looking at any precancerous cells that do not look right, and these are destroyed in the body so that you do not develop cancer. If you have a defective immune system, then these precancerous cells will develop into cancer. Then there's, of course, genetics. And here you can look at genetics at different levels. The genetics, which are population genetics, so some people just have a higher risk of getting certain cancers, but there's genetics where some genetic mutations predispose you to cancer. You guys have probably heard of things like the BRCA genes and Gardner syndrome. We'll talk a little bit when we talk about colon cancer to that. During the time leading up to our discussion, we talked about exposure to some toxins. So the toxins that increase your risk of getting cancer, they are called carcinogens. Floribert mentioned earlier about radiation, exposure to radiation, be it radon, be it just a natural background radiation, be it other sources of radiation. The most important risk factor to cancer, though, is age. And I have heard many people say we are no longer as young as we used to be. Yeah, the older you get, the higher the chance of you getting cancer. Then there are cancers that are certainly more prevalent in females than males, and others more prevalent in males than in females. The one where we have an input on is really the lifestyle. This is where we need to focus our attention. We have a choice of what type of lifestyle habits we enjoy and to what level we enjoy those habits. And it's important to know what role they play in our cancer risk. So those here I will mention, there's obesity. I know when I was growing up in Cameroon, if you got married and your wife was fresh and big, they say you're feeding her well. Well, we know, be it in the United States, Europe, or in Cameroon, obesity has a lot of associated illnesses, and cancer is one of the risks that it goes along with it. Big one we can modify is smoking, and it's not just smoking cigarettes. I know my mother and uncles, they use tobacco, whether it's snuff that they take, they put in the nose or they put in the mouth, all of that does increase your risk of cancer. Then excessive alcohol consumption, and we are hopefully going to discuss later on. Alcohol can have protective effects, but excessive alcohol does increase your risk of getting cancer. Then there are reproductive changes. We'll talk some more when we talk about breast cancer. And then, of course, sexual promiscuity is linked to infection, but also other risk factors that are not necessarily linked to infection that can increase your risk of cancer. So I thought I focus a little bit more on breast cancer because that's the most common type of cancer, not just in Cameroon, but worldwide. So some of the risk factors, the one that a lot of us are probably aware of is, so the principle about risk of breast cancer is that the longer you are exposed to estrogen levels in your body, the higher your risk. So generally you have early menarche, so your menses start early, then you are exposed to estrogen just over a longer period. You have late menopause, that just increases how long you've had high levels of estrogen in your body. That also goes now with women who are never pregnant or they get pregnancies late in life, they have a higher risk of pregnancy of breast cancer. There is very clear evidence that women who are on hormonal contraception, so oral contraceptive pills for a long time, or when they are treated for postmenopausal symptoms with hormone replacement therapy, we know that one of the side effects is that their risk of breast cancer goes up. But we also know that excessive alcohol use, obesity, but importantly, family history. If you have a family history, a relative who has breast cancer, your risk of breast cancer is higher. If it's a first degree relative, like a mother or a sister, then your risk is even higher. Those who have had breast cancer and once before, they have a risk of getting breast cancer again. And then most importantly, young people can have cancer too, but cancer is mostly a disease of the older folks. So age 50 and up, the risk of breast cancer goes up significantly. But it doesn't happen at 50, it just goes up progressively over time. That's why a lot of women, they will say starting age 40, you want to make sure you're getting routine evaluations for breast cancer and screening. So what are some of the breast cancer signs and symptoms? So I will mention that a lot of these signs and symptoms here will happen for many reasons. Having them does not mean you have breast cancer, but generally you have them that should make you go and take a look or talk to your doctor, get a closer examination. So breast pain, for the women in the group here, they will tell you during the cycle, there are breast changes that happen, and then there are some phases of the cycle that they will have tenderness there. So key is really when that changes, so it does not feel like it has always felt, and that's something you really want to make sure you pay attention to. Then breast lumps, again, breast lumps are actually very common. The adenomatous breast lumps that are very common, and 9 out of 10 breast lumps are not cancer. But if you feel a breast lump, you want to, especially if it is new, you should have that checked out. There are some of these breast lumps, again, they will change in course of your cycle of the month. But most girls and women, they will know how that has been. So you see a change in the pattern. That is what should prompt you to have that look at. You have nipple discharge. Again, if it is milk, that's not usually a problem, but especially you see bloody discharge from the nipple, that needs to be checked out. That is a very concerning symptoms that need to be evaluated, and cancer needs to be ruled out. Then there are skin changes. Sometimes it will just be the skin peeling off. Now it could be that you change your soap. It could be that the disinfectant in the water has changed, but it could also be that you have breast cancer. So especially skin thickening, you want to have that checked out. If you see a retraction, so the skin around the breast, any part of the breast, if it is retracting like a dimple, it could be that the underlying tissue, there's an issue going on. That's why you have that needs to be checked out. We have had situations where people show up with wounds or ulcers in the breast, and that is breast cancer. We call it ulcerative breast cancer. Some people, you feel lumps in your neck, you feel lumps in the armpit. So the lymph nodes that drain the breast generally go towards the armpit. So if you have the cancer spreading to your lymph nodes, frequently they will spread to the armpit. That's also why frequently when someone has breast cancer, they will explore the armpits to look at the lymph nodes and make sure it has not spread there. So you feel bumps there, that could be a concerning finding. One of the key things about breast cancer is it's not really mammography or the doctor's exam which is going to find breast cancer. It's frequently the woman who finds the breast cancer. So what we really encourage, especially at this age, but even you have younger children in their 20s, is really have girls get used to frequently examining their breasts. Key is so that they know how their breast normally feels like. That way, if there are changes, they will know that it has changed. I think there are some cultural things that discourage people from doing that, but it's very important. Every woman should know what their breast feels like normally and in course of the cycle. That way they will know when things are different. Because the key to surviving breast cancer, and breast cancer is very survivable, is one of the most treatable type of cancers in the world, is early detection. If you catch it early, you have a very good chance of cure from your breast cancer. So hormone therapy is very important, and we use it all the time for different reasons. But if you can limit the use of hormone therapy, be it for prolonged contraception, that is certainly to be considered. but using hormone replacement therapy in menopause is something that is widely used and frequently needs to be used because of some of the debilitating effects of menopause. We use it a lot in girls and women with bleeding disorders. So to control the period, we use it for contraception. So again, we do say they increase your risk, but the increase in risk is not that dramatic that we will say don't use it. So, but if you don't need to use it, you don't have to use it. Based on this, there are other forms of contraception that we encourage people to use, especially if they have a significant family history of breast cancer. They have a BRCA gene mutation, which we will mention again later on. Alcohol is a social drug. All of us, we take it all the time. I do drink alcohol, but you want to limit your alcohol use and don't abuse it, and try to strive for a healthy weight. So we are not going to go into what's obesity, what's overweight, but a lot of us, we know what a healthy weight is. So trying to not be excessively overweight will certainly reduce your risk. I wanted to take a few minutes and just go through some of the myths that people have about breast cancer. And I hope we can have a debate on this, because I do anticipate some debate on this. One, people think that only women can have breast cancer. No, men can have breast cancer. In fact, breast cancer is actually about 1 in 1,000 men will get breast cancer if you were to take their lifespan. So it's a common breast cancer. Men have breasts, so yes, they can develop breast cancer. Having bras with tight wires or lifts on it is not going to increase your chance of getting breast cancer. Or any injury because somebody beat the breast or some other trauma to it. Yes, the breast will heal. It's not going to increase your risk of getting breast cancer. There's this discussion that women with big breasts are going to have a higher risk of cancer. Looking at the data in different parts of the world, there's really no data to suggest that women who have big breasts have a higher risk of getting breast cancer. And not just like other tumors, there's no concrete data to suggest that using phones, be it up to your ear or you're storing it in your bra or in your pocket, that does not increase your risk of getting breast cancer. Abortions do not cause breast cancer. That is something that people say. Then I know we were joking about this the other day, that sucking on breast by the partner will reduce your risk of breast cancer. That is not true. Actually, investigated, apparently there was a comment some years ago on the BBC about some doctor in Ghana saying that that doctor did not say that. What people confound this with is the fact that breastfeeding does reduce your risk of breast cancer. When you are breastfeeding, if you go back to some of the biology that we studied in secondary and high school, when you are breastfeeding, you do not have your period as often. Or even when you get it, if you measure the estrogen levels in your body, you do not have the levels that you normally have. As I said, breast cancer, depending on your circulating level of estrogen, you are going to have a higher risk. So the women who breastfeed for 2 years, they are going to have overall less levels of estrogen circulating in your body. So the longer you breastfeed, the lower your risk of cancer. The more children you have, the longer your lifetime of breastfeeding, the lower your risk of cancer. But having your spouse suck on your breast is not going to reduce your chance of getting cancer. However, it's not a bad thing to do. The reason being that the more people pay attention to the breast, the more likely that if there's a problem with the breast, it will be noticed. So in addition to that, the woman paying attention to the breast, if the spouse likes sucking on the breast, they will probably notice a change in the breast. So that would be a good thing in early detection. The other cancer I wanted to spend some time with, because I know that we cannot look at all type of cancer, was to look at prostate cancer. Prostate cancer is actually a relatively common cancer. And I'm going to say some things about it that maybe come across as controversial, but you have to go by what the data says. So the older you are, the higher your risk of getting prostate cancer. When they look at autopsies in people 90 years and older, they found that more than 80% of them had some occult form of prostate cancer. So as you live, if you are a man and you live to be old enough, there's a chance you're going to have some form of prostate cancer. In general, people of the Black race have higher risk of prostate cancer. This is mostly true for Black people in the United States, Europe, and in the Caribbean. Prostate cancer is not as common in Africans who live in Africa. So there is certainly a geographic propensity to this prostate cancer. One thing though is that Black people in America, they generally live longer. So that's probably one of the reasons why we have higher incidence. But when they adjust for age, they still see that Black people in America, they have much higher risk of prostate cancer than Black people in, well, let's say, in Cameroon. So it's not quite clear what the geographic influences are, but lifestyle plays a role into that. What is not so clear in prostate cancer is if obesity plays a role, if smoking plays a role. They are suspected to play a role, including sexually transmitted diseases. But the data on that, there are some studies which show it one way, some studies show it the other way. So that the jury's out on that. But it's not a bad idea to not drink too much, to not get STDs, and reduce smoking. So some signs of prostate cancer, again, these are actually going to be going to overlap with what we call prostate hypertrophy, but sometimes really difficult to tell the difference without imaging or even getting a biopsy. So if you start noticing that when you go to pee, it takes a while for the urine to start coming out. The urine is coming out, it's a weak stream. And then you pee, it looks like you cannot complete the peeing. After that, your pants still get wet. You have to have a concern that you may have something wrong with your prostate. You have painful urination. There are other reasons. You could have an STD, but it could also be that you are having a prostate cancer. If you see blood in your urine or semen is never normal, don't say, oh, it's because I had sex 3 times, that's why I am having blood there. No, you should not have blood in your urine or semen. So if you see blood there, that needs to be checked out. As we age, erectile dysfunction becomes just a common problem. But if you suddenly start having problems with erection, it could be that you may be having prostate cancer, so that would need to be checked out. If we remember our days in secondary school, you know that the prostate sits right there as the urethra comes out, and then the seminal sac, the seminal canal, the cam, they go right through the prostate. The prostate is sort of enveloping it, but between that, so between our bladder and our rectum, that's also where the prostate sits. So your prostate gets very big. Not only does it obstruct your ability to pee, it also may obstruct your ability to have stools. So you start having constipation and all of that. That by itself can be a sign that you have prostate cancer. That becomes a bigger problem, is that invading the nerves that help with you controlling both your bowel function or your urination. You can lose control of your bowel. Then if this becomes metastatic, so it starts spreading, you could have weakness, muscle weakness, you could have bone pain, prostate cancer. So those last 3 will be a pretty advanced stage of the cancer. You start having those. So early detection for some of us who live in places where they do early detection, we have the fun of going to the doctor and they're doing the digital exam. So they check out our prostate to see how much bigger it is or if it's enlarged, go for that. There is the prostate-specific antigen. This has to be interpreted with caution. I will tell you that in the United States, the screening is really individualized. The reason is prostate-specific antigen is not specific to cancer. This antigen is made by all prostate tissue. It's just if you have more prostate tissue because it's growing out of order, out of control, it's going to go up very high. So it's really important to see, let's say, the prostate-specific antigen was 5 today, and tomorrow is, or next year you come is 18, then that's a problem. If you came and it was 18, it could be your prostate just produces more of this antigen. So there's really not a clear cutoff that you come in, this means you have cancer. But if there's a dramatic rise, that's certainly something to be concerned about, and you will need a biopsy. But there are just some levels where it comes in so high that you need to go ahead and get a biopsy. Make sure you are not dealing with prostate cancer. How do you prevent prostate cancer? As I mentioned earlier, there is no sure way to prevent prostate cancer. Again, you can live a healthy lifestyle, make sure you control your weight. There is something to suggest that you eat a lot of foods with high calcium content that increases your risk of cancer. So reducing that may help you a little bit. Vitamin and mineral supplements have been shown to, in some studies, to reduce the risk of you getting cancer. But one thing that we know I think we know about even before you go to medical school is that pumpkin seeds may help with reducing your risk of cancer. We certainly know that they do reduce the risk of prostate hypertrophy. And and when you do what we call in vitro studies, where you take the extracts and you put the cancer cells directly, it clearly shows that it inhibits cell proliferation. So it reduces the rate at which cells are growing. So you can extrapolate that what people describe that it certainly has the potential to reduce your risk of getting cancer or reduce the rate at which any cancer is growing. So it's really important to do this monitoring. The key is making sure you listen to your body. If things start feeling different, and that is really what matters. If your body starts feeling different, you need to acknowledge it. We like to ignore it because we are afraid of what it may be, or we think that it cannot happen to us, but you need to acknowledge it and seek out medical care. Treatment for prostate cancer varies. So in many cases, it's observation. So I would tell you, see somebody who's 80 years old and you diagnose them with prostate cancer. If it is localized, you leave it alone because probably something else is going to kill them in the next 10 years. So you don't go do radical surgery. Some of those, if it is, you can monitor, say, like PSA, if it starts rising dramatically, you go treat. But when you treatment frequently will involve surgery. If you are people who are younger, let's say, if you treated a cancer, they have a good chance that they will live the next 5 to 10 years without something else killing them, then you want to be radical with the treatment. So frequently you consider surgery. If you cannot take out everything, there are different forms of radiation therapy. There's what we call conventional radiation therapy, where you get an external source of radiation. There's what we call brachytherapy, where you implant seeds of radionuclide in the surgical bed or in the prostate itself. So you have very limited radiation there. Then there's chemotherapy. But some people who have a very extensive disease, especially if they're a lot older, you can skip all of this. Prostate cancer is very dependent on testosterone. So a lot of times if you can block testosterone, prostate cancer will not grow much. But of course, you block testosterone effects, you are going to have a lot of third leg problems. But for people who are too old for radical surgery and they don't really have issues with having a functional third leg, then you can certainly use hormone therapy to avoid being very aggressive with surgery. So I think I mentioned some of the myths about prostate cancer. Again, PSA is made by all tissue, prostate tissue, so it can be elevated even if someone does not have prostate cancer. Yes, there is a risk of sexual dysfunction after treatment for prostate cancer, be it a hormone treatment or if you do surgery. But most men who are treated for prostate cancer are able to retain their sexual potency. So that should not be a reason not to consider treatment. Again, you have to be alive for your third leg to work. So you worry about third leg and you're not around, and that's really not of much use to you. But even advanced prostate cancer can be controlled. As I mentioned, in some of those cases, you can use hormone therapy by blocking testosterone effects. You can slow the growth of prostate cancer or even halt it completely. Some other common cancers I wanted to go into, but we are getting up here. I wanted to mention a little bit some of the issues with colon cancer. So colon cancer is a very common cancer, as we saw, is the third most common cancer. You look at worldwide data. For a long time, it was more common in what we call the advanced economies, but it's getting more and more common in Cameroon and other less advanced economies. The main reason is that we are changing our dietary habits to what the Americans and Europeans do, especially those of us who are able to afford that diet. We think that is a superior diet, but we know it certainly is not. So the more processed foods you eat, the higher risk, of getting colorectal cancers or cancer of the large colon and the rectum. We don't have it so much in the small bowels. The less roughage you have in your food. So those of us who grew up eating a lot of njama, with not much with eating meat only on Christmas Day, we were doing ourselves a favor by reducing our risk of colon cancer. But that is changing too, that we are eating. And of course, we know that obesity does increase your risk. Alcohol especially increases the risk of things like gastric cancer and esophageal cancer. So again, drinking alcohol in moderate levels should not be a problem, but you drink excessive alcohol, that does increase your risk significantly. So what are some of those things to pay attention to? Constipation could be one of it, but you start having belly pain that you do not have an explanation. A lot of us will say it's gastric. Gastric is pain that's generally right in your chest. That's why they call it heartburn. It's right below your ribs there. You have pain in the rest of your belly. That's not going away. It's not constipation. It's not bloated. You pass gas, the pain remains there. You want to have that checked out. If your diet has not changed and you all of a sudden start having constipation, you want to have that checked out. It could be that there's something that's obstructing the way things are moving through your bowel, and you may want to check that out. But again, having blood in your stool, though it could be that you have some parasites, but you should then go and have testing to see if you have parasites causing it. Otherwise, you want to be checked to make sure that it's not colon cancer. If it's colon cancer is really one of those that the sooner you catch it, the better your outcomes. That's again why in places like the United States and in Cameroon to an extent, they do this colonoscopy. So I need to get my annual colonoscopy. It's not a fun thing to do, But once you get to this age, they recommend that you do it. And there are places in Yaoundé and Douala where you can go get it done very routinely too. If they pick it up on time, all they may do is during the colonoscopy, they scrape it off, they look at it, they say they got at everything, you're good. But even if it's more than that, they need to do more surgery. It's better to catch it early than not. Some other thing I just wanted to mention briefly that could be signs of cancer. If you're coughing up blood, that could be a sign of either cancer of the airway or lung cancer by itself. So that should not be ignored. If you start losing weight and you do not intend to lose weight, then that could be a problem. People who you start sweating a lot, and you get up, your bed is wet as if somebody had peed in the bed, then that may be a sign that you have cancer, and you may want your doctor to check that out. Situation that I'm dealing with some in the family now is brain cancer. Brain cancer is actually very difficult to pick up early. So if you have headaches, the headaches do not just sound right. You want to go have the doctor check you out. They may pick up that there are some changes in your strength, it may be your vision. Those will be early signs to look that if it is headache, that it can be checked out. I'll just give a word of caution here. CT scans of the head are not very good to pick up brain cancer. So to rule out breast cancer, you need an MRI. There are 3 places in Yaoundé where you can get an MRI. There are 2 places in Douala you can get an MRI. MRIs are not as expensive as I thought. They cost about 300,000 for an MRI. But if you're really having headaches that are not going away, they do a CT scan, they say there's nothing, you may want to push that they get an MRI to make sure if it is brain cancer, that's picked up on time. Again, because those 2, this earlier you pick it up, the better chances. Other signs of brain cancer could be people getting up in the morning and vomiting. So you get this early morning vomiting for absolutely no reason. You did not eat anything that was unusual. Sometimes this vomiting is even without feeling like throwing up. That could be a sign that you may need your brain image. Other signs of cancer, you have bone pain. It could be bone cancer. Bone cancer is not very common in Cameroon. It's one of those less common ones, but frequently it's cancer from other places, be it breast cancer, be it prostate cancer, spreading to the bones. So that could be a problem. Leukemia is a common cancer, but it's in Cameroon, it's not even among the top 10. But one side of leukemia could just be bleeding and bruising. That is your bone marrow being overwhelmed and you don't make enough platelets, and that leads to you bruising and bleeding more. So cervical cancer is a very common type of cancer, especially in less advanced economies. In most places, they will do what we call perpendicular smear, called pap smear. In Cameroon, most of the time, they just do direct visualization. And they may do potassium hydroxide to visualize, and they can actually see if the areas there that look cancerous, and the gynecologist can at that moment scoop it out. So it's very important to have those frequent cervical exams or vaginal exams to make sure that they visualize the cervix for that. This is easily done in Cameroon. I have several family members who go routinely and get it done. If you can make your way to the major places, Yaoundé, Douala, you go to places like Beng and the rest, these are done very easily there. Again, for men, testicular exam cancer is not one of the top things, but the only way you are really going to pick up testicular cancer is you do Excel exam. Just like we say women should do breast cells exam, men should get very comfortable to know how their testicles feels like. That way, if there are changes, you will know that there are changes and you will seek the help that you need. So overall, what are some of the preventative strategies for cancer? You should avoid the risk factors, which you can. So the risk factor that we cannot avoid is the risk factor of age. So it's a privilege to get older. I mean, a lot of our classmates who do not get to the age we are, so we should be thankful for that. And those of us who get to be 80, 90, we should be more thankful. But that's something you cannot control. You get that, but you can control what you eat, you can control what you drink, you can control where you live, you can control some of the things that you expose yourself to. We can look at food storage and processing. I didn't go into some of the issues that we have. One of the things is the aflatoxins that foods we have in Cameroon. When I look at, when I was growing up, when I'm peeling granules for my grandmother, even the ones that have obvious fungus on it, I will eat it because the other ones you have to keep so they can go plant. Those aflatoxins, they actually increase your risk of cancer, including liver cancer. And liver cancer is actually a common cancer in Cameroon. Somebody has precancerous lesions, especially things like cervical cancer, you want those identified ahead of time and taken care of. Now, these are some that I feel very strongly about, and I know that some of the controversies in Cameroon, including some of the politicization, has really hampered us. These last three, these are the ones I call infection and preventable cancers, mostly in Cameroon. So hepatitis B is the leading cause of liver cancer in Cameroon. For those who are in the medical field, be it in Cameroon or elsewhere, you have noticed that a lot of Cameroonians, when they're tested, they have been exposed to hepatitis B at some point. If you're lucky, you're exposed and your body takes care of it and you're done. But there are a good number of people who have chronic hepatitis B infection. And this has a high propensity of leading to liver cancer down the road. Hepatitis B vaccine is actually part of the immunization, children immunizations in Cameroon. The unfortunate thing is that they do it in this vaccination center, what we used to call the clinic. The first dose, which is actually the most important dose for mothers who are hepatitis B positive, has to be given when the child is born. I will tell you here, we give it to the children in the first 24 hours of life. That way, if the mother has hepatitis B, the baby will not develop it. That one in Cameroon, you have to pay for it, and it costs about 30,000, as I was reading through. That suggests that a lot of people do not get that first one when the child is born, including parents who, the mothers who may be positive or who may be chronic carriers of hepatitis B. But if we can really eliminate hepatitis B, we would drastically reduce the incidence of liver cancer in Cameroon, which is a deadly cancer. Hepatitis C also causes, can also induce liver cancer, but it's not as common as hepatitis B. And we do not have a good vaccine. Hepatitis B vaccine is very, very effective. Then there is the human papillomavirus, which is the leading inducer of cervical cancer in women, and not men will carry it and transmit to women, and then they deal with the effects of that. So the HPV vaccine, which is a routine vaccine here, my children all received it when they were 11 years old, boys and girls, was piloted in Cameroon. It's not yet part of the routine immunizations in Cameroon, but this is one of those that has been very controversial because when they piloted it, just like here, by the way, in the United States, they first started vaccinating the girls, and it was girls in childbearing age. So, of course, people ask, why are you trying to vaccinate just my girls? And I remember in Cameroon, the question was that they wanted to sterilize our girls because the Bill Gates and the World Health Organization, they don't want people to have children. That's very unfortunate because with this vaccine, you can drastically reduce the incidence of cervical cancer. The Then HIV, for those who have worked with people with HIV, you know that they are at increased risk of getting certain cancers, and just treating them. So with the HIV medication project that was partly funded by the United States and all around they call it the PEPFAR program, that has reduced the rate of HIV, but that has also now reduced the rate of these cancers that are linked to HIV. So these are all infection-related cancers which are very highly preventable. So I'm running into an hour here. I wanted to just give people a few resources for cancer care resources in Cameroon, then we can discuss any other questions that people have, including other cancers. Is again, cancer care in Cameroon is in infancy. There are really no standard protocols. I have run into the people who treat, and Bingo actually uses pretty good protocols. They work with Johns Hopkins here. So a lot of their protocols are actually based on the ones that Johns Hopkins uses here. Now with the crisis, I don't know how operational they are, but I will tell you, based on what I have heard and talking to the people, that would be somewhere if somebody needed treatment for cancer, I would send them there. They have tumor boards that are live streamed to major cancer centers here in the United States. More and more other centers in Yaoundé and the one in Douala, they will do tumor boards with cancer centers in Europe and here. So General Hospital in Yaoundé and Douala, they have cancer centers, but they are very disorganized. I can tell you, you go, you have to advocate for yourself. You have to be one asking the oncologist to see you. There's no automated referral that somebody sees you and say, okay, go see this person, go see this person. You have to try to navigate that all by yourself. Radiation therapy is currently only available in Douala, at the General Hospital in Douala and at the private Cameroon Oncology Center in Bekoko at the entrance to Douala. The radiation therapy machine Yaoundé has been out of the radiation source since 2016, so you cannot get radiation therapy there. And then nuclear medicine, which there are some treatments that we use, nuclear isotopes. The Nuclear Medicine Center in Yaoundé was closed in 2019, and the current cancer prevention strategy does not foresee what they want to do about that. I know that there's a friend of mine here who works with the International Atomic Energy Agency, has been in contact with the Ministry of Health in Cameroon to see if they can get a linear accelerator in Yaoundé for a radiation source. But so these are some of the imaging services that are available in Cameroon. So CT scans and MRIs are very important for cancer diagnosis. But you see, as I mentioned, the MRI is not functional in most places. But I mentioned if you go to Yaoundé, though they say a lot of these are not functional, the military hospital in Yaoundé, their MRI is working very well. There is a Cathedral Hospital in Yaoundé, their MRI is working very well. And then there is a private center too there in Yaoundé who has a very good MRI. You can actually get MRI on the same day there. Health facilities which are offering chemotherapy again, if you look at General Hospital in Yaoundé and Douala, then you have the Bingo Baptist Hospital, as I mentioned. If you were to go back 5 years ago, probably the best cancer center in Cameroon was the Bingo Baptist Hospital. Just to give you an idea, these are the personnel that they have to treat cancer in Cameroon. Again, there are people who treat cancer, just a lot of them are not trained. Chemotherapy in Yaoundé, the nurses mix it, they don't have a chemotherapy pharmacy to do that. There are only 5 surgeons who are trained as oncology surgeons in all of Cameroon. They have just 3 pediatric oncologists. Just to give you an idea, In Eastern North Carolina, my division, we have 6 pediatric oncologists. So it just gives you an idea. And when you go, that's also why you need these people are there. They're taking care of thousands of people. So they're not going to have the time to spend with you. So it's not even that they don't want to do their job. It's just they're limited in what they can do. In all of Cameroon, there are only 6 medical oncologists that are trained. So, and again, this is from 2018 data by the government. It's not from another source. So these are things that I can tell you that a lot more Cameroonians, here in the United States alone, I know at least other 15 Cameroonian pediatric oncologists. And sometimes the question, what role are some of us playing, just not helping out the country? But I think I will stop here so that we can discuss what people want to talk about. Thank you for your attention.
Okay. Oh, thank you very much. Thank you very much for this talk. You remember we agreed that this was just an introduction, and that with time we'll go to specifics. That is to say that we'll pick prostate cancer, we talk about it, breast cancer, we talk about it, and so on and so forth, so that people have an in-depth of what is it that awaits them. I can assure you that personally, I have a lot of information from what you have presented today that I didn't have before. And I think it's the same with our mates, those who are here and those who are out there. Thank you very much. I think we should get into full discussion. And I think our mates, Dr. Beng did say that he didn't want us to make it a question-answer session, but it should be more of a discussion. And we should feel free, we are all classmates, we should feel free to express ourselves and then see how much we can gain from this rich knowledge that he has brought onto this presentation today. So I'll leave the floor open so that we can start with the discussion. Like I said, if you just raise your hand, we will come to you, and then you ask your questions. And then we can also watch out for those who are following us on YouTube. Whatever questions they have, we'll come back and post them here so that they can be answered. So I'll leave the floor open. Myself and Abeti and Flaubert, we are going to conduct this part of the discussions. And I think Dr. Beng, just leave the slides. You may need them, I think. Except you think that you want to start seeing people's faces, then that's fine.
No, that's fine. I can see faces on the corner. Okay.
All right, then let's Flaubert, you want to ask the first questions? Go ahead. Unmute yourself, please.
Yeah. Can you hear me?
Yes.
Yes, Buddha Mensch. We hear you.
Okay, my question is about breast cancer. I was thinking that maybe some of our habits, bad habits that we have back home, like in general, the female or the genital mutilations, and in particular here, breast ironing, as they call it, does it have any impact on breast cancer occurrence in female?
So that was looked into, particularly when they actually mentioned the myth of trauma, because that was an assumption that breast ironing or other forms of trauma to the breast would increase the risk. And based on the fact that we know that excessive inflammation does have a tendency to induce cancer, but the data did not show any increased risk because of trauma, be it from blunt trauma or things like breast ironing. So it's to be deplored, and there's a lot of other medical issues of that, but it does not specifically increase the risk of cancer.
Okay, thank you.
All right, Collins, go ahead with your question or your comment.
Okay, thank you guys for organizing this. I think it's very enriching. Dr. Beng, thank you so much. Well, on a lighter note, I always like to joke first, but I think, Dr. Beng, if you're going for any political, if you're going for any political position, you might be careful. The fact that you said sucking breast does not help this thing, I think young men will not like that. Anyways.
Frunga would not like that.
Frunga. Anyway, so you talked about breastfeeding and lowering of estrogen levels. That's something that I think a lot of people don't know. And the number of kids you have and stuff, I know that disposes you, if many more kids, will be other medical conditions like diabetes in the end and all that stuff. If you can touch more on that, as well as maybe birth controls as to the effect of estrogen levels in relation to breast cancer, I really appreciate. Thank you so much.
I mean, I think you said it all, right? So as a pediatrician, I could go on and on about the benefits of breastfeeding for the child. But I do think that one of the tools that we use to encourage our modern mothers to breastfeed is to tell them that it's actually very beneficial to you, including reducing your risk of breast cancer the longer you breastfeed. I don't know how the environment is in other countries. I know that women have a lot of challenges about breastfeeding. I imagine my mother, she had to get up at 6 o'clock, go to the farm, and then she will only come and breastfeed the baby at the end of the day. Here, my colleagues at work, every unit has a breastfeeding room. So we, new mothers, you have to give them half an hour every 4 hours so they can go pump their breast milk. So some people do have the luxury to be able to breastfeed and to be able to keep up. Unfortunately, some people, based on what their lifestyle, the type of jobs they do, they cannot. But yes, at the level of the mother, it clearly decreases your risk of not just breast cancer, you said, many other health benefits, including they lose the pregnancy weight faster than if they were not breastfeeding. For their babies, it reduces the chance of the baby getting diarrhea and ear infections, so they don't have to go to the emergency room or go to the doctor or buy antibiotics. So we could go on. But that's one thing. But yeah, it does influence your hormone balance when you're breastfeeding. The prolactin that you use that helps to drive the milk production. But more importantly, it influences the balance of your progesterone, your estrogen, which are some of the drivers. So your overall lifetime exposure to estrogen that increases your risk of breast cancer. I don't know how much deep I can go into it, but I do think that clearly most of our mates who are females, they should be done with childbearing, but they can certainly encourage their daughters, and we should encourage our daughters, they have children, that breastfeeding is going to have a lot of benefits for their children, but for them too as individuals, not just at the level of reducing their risk of breast. It's not that you cannot have breast cancer if you breastfeed, but it also reduces your risk of other medical conditions. I would like to add here too that as someone who looks at population health, you should not have 10 children just because you want to breastfeed all of your life. There are many other implications to having many children, right? So,
Sure.
And the implications on the mother's health, both physical and mental health, but the implication on the children. You cannot feed the children, you can't send them to school, you shouldn't be having them. Again, that may be getting too political here or philosophical, but
That's okay.
I think you cannot sustain children, don't have them.
Yeah.
Okay. I thought that I should just add that.
1 second, Joanne. I think Doc missed the second part where I asked about estrogen levels and birth control pills.
Yeah,
and how that
I want
affects.
just to say that
Okay.
we said this is a broad. He just did an intro touching a wide range of the cancers that are probably going to touch us if we don't take care of our health. And so we in my discussion with him, we did agree that we'll pick one of them, one after the other, and get into them specifically so that we can discuss in depth. I think so, yeah. So if he has not answered the question fully, this is not for you, this is for all of us. If he has not answered the question fully, we should rest assured that this topic is going to come up again, but now with specifics. It's not going to be a generalized topic the way he
John,
did.
can I briefly answer him? I think I hear what he's talking about.
Right. No. I'm saying that you can go ahead, but if none of us feel satisfied, we should know that we still have time to get into more details of everything. That's just what I'm trying to say. So you can go ahead, please.
So I know what I'm trying to I'm dancing around a little bit, my brother, is I know that birth control in Cameroon can be very controversial sometimes, and I don't want to contribute to stigmatizing birth control, right? So, but clearly what I encourage is people should use the lowest necessary estrogen doses. So if you look at birth control, there are low estrogens, low estrogens. So those who prescribe birth control, they will tell you that the industry, they are trying to lower the doses of estrogen as much as possible while still maintaining the efficacy that is necessary. There is progesterone only products and all of that. So if somebody is going to take birth control, be it to prevent pregnancy, be it because they have heavy periods and they need to control the heavy periods, be it because they need hormone replacement therapy after menopause, you want to use the lowest necessary dose.
Thank you so much. I just wanted you to touch on that. Appreciate it.
Thank you, Collins, for your question. Then we'll take Tekla. Then after Tekla, we'll take Evelyn. Tekla, please ask your question or your comment.
Hello, good evening, everybody. Thank you, Dr. Ben, for this wonderful presentation. I saw on the presentation that you said excessive consumption of calcium is not very good for us. But you know, with our age now, we have been taking calcium supplements. To what extent can you say the supplement is excessive?
And I think there is a talk coming down the road about bone health, right? Which will contradict some of what I say. And I run into this actually with children, for example, where you want their bone health to be good and they drink too much milk is not good for their iron. So I think everything needs to be done in moderation. First of all, let me be clear that this was about prostate cancer where there is some indication. The data is not affirmative. So there is something to suggest that if you go a lot by what the Center of Disease Control says. So the Center of Disease Control says that this is a speculation. It is not an established fact. So I will say if especially you have bone issues, you should take your calcium supplement. Do not spare on it because I mentioned that it may increase your risk of prostate cancer. Especially if you're a female, don't even worry about it. Right? So, but for males, I think if you're taking your daily calcium, you are fine. But if you are there eating yogurt, drinking 3 cups of milk a day and taking calcium 3 times a day, that's probably an overshoot. One, you don't need that. It doesn't matter what your bones or dental health looks like. That's excessive. So I would just say don't take If you are taking one pill a day, it's what we call one a day men or one a day women here. Women too, when they go into menopause, they do need to really keep up with your bone health. So I would tell you, I take once a day men, okay? It has other minerals, it has calcium, it has vitamin D. So I take that once a day. That's not a problem, but it's just not to go overboard.
Okay, thank you very much.
Evelyn.
All right, thank you, Dr. Beng, for this wonderful presentation, and good to see all of you on board. It's my pleasure. My question, Dr. Beng, when one of the slides, I did see that we shouldn't be worried about cell phones that can cause breast cancer. You know, it's something that we always say, don't put your cell phone, you know, close to your breast because there's irradiation coming out of that. So how do you debunk that myth of the concern of irradiation coming out of a cell phone? And then my other question is on prostate health. Yeah, we know there's a lot of issues. Well, it's a common cancer, well, not really cancer per se, common presentation, be it in a benign form or in a malignant form. So what do you tell someone that is concerned about having issues with prostate that as it is, don't worry about it, it's just a benign thing, or it is something that is more serious, being cancer coming up?
I will start with the cell phone controversy.
Yeah.
Again, what I like to go by is, perhaps I should have been clear, I said, based on what we know today, right? Because what we know today may turn out not to be what we know 50 years from now. So the issue of cell phones and cancer, I would say breast cancer is just one. Big one has been brain cancer because we put it to our ear. So that's where there has been a lot of research, a lot of data trying to look if there's a correlationship. So to date, despite a lot of funding put into it and produce good data, there has not been an established relationship between you where you put your cell phone and cancer. Now, just as a human, as we interfere with nature, we bring things to us, we have to assume that there may be some interaction with our metabolism, and that may have consequences down the road. So yes, I do not carry my cell phone on me all the time. When I go to the office, like now, I put my phone on my table. I don't leave it on my pocket. So the data says that it's not going to do anything if I have it on all the time on my ear, but these things change over time. So there is no guarantee for that. All I can tell you is that data has been looked at for breast cancer, has been looked at specifically for brain cancer, and it has not been established that having the phone in the vicinity of your head or your breast increases your risk of breast cancer. There may be other things that happen, it's just not been established.
Okay,
I don't know if that is a satisfactory answer, but I would say if you can avoid having your cell phone on all the time, and you can, the further you keep it from your body, I think long-term, it's safer. There may be health issues that we don't know.
Or even turning in on airplane mode.
If you can turn it off, that's good. Nowadays, sometimes it's difficult to turn off your cell phone. We depend on it so much, right?
Okay.
And then for prostate, I will tell you that he is really, as I mentioned, benign prostate hypertrophy is very common, especially in us people of African descent. He is really paying attention if you start having symptoms that you get looked at. I think at our age, if we have it, we should be aggressive in managing it. I think 20, 30 years from now, when we are older, I think if you develop prostate cancer at that time, by the time it really causes problem, your heart will probably fail or something else will fail, right? So I think it's in the 80s and the 90s that people are like, okay, what's the risk versus benefit of treating prostate cancer very aggressively? But I do think that now is really important to pay attention, especially people start having weak urine streams or there's this hesitation. You can actually tell. So, you know, we men, we go to the pissoir, so you see somebody can stand there, it takes about 30 seconds before they start pee. You can almost say, you, sir, you want to go have checked out, right? So it takes a while for the urine to start flowing. So you start having that.
Doc, please kindly let me, Daniel, please, can you mute yourself? Please, Daniel, can you mute yourself? Daniel, can you mute yourself, please?
Thank you so much, Dr. Konya, for leading this.
They're probably not paying attention to us.
You can see how.
Okay, I'll put him in the waiting room for a while so that.
I'm sure we'll still have questions going forward.
All right. Okay, I'm sorry, Doc. Go ahead.
Yeah. So, Eve, I don't know if I answered your question, but I do think that we do need to pay attention to it. I do think that if you have every man at our age, they should have their annual digital exam. They will pick up on a hypertrophic prostate, and then they may pick up on cancer as well. I think if you have a hypertrophic prostate, you should have that the PSA done, and you may want to get that image, and then you may want to get a biopsy of that to make sure it's not cancer. Now, if it is, you know, the whole stages, if it is this prostate carcinoma in situ, they may be able to do it very safely, use a transurethral way and with very limited risk, right? So I think if you have symptoms, you should certainly see a urologist. Well, you should see a doctor. In the United States, it will be a urologist, but elsewhere it may just be a regular doctor.
Please, any other question or concern or anything that you think we should talk about? Maybe I should just ask mine now. Dr. Beng, you are.
So can I just make a request? Since
Yes,
we are mates here, we can just say Beng, right? I don't know why people call me Dr. Beng.
No, I must call you doctor now because now you do presentation. So
okay.
Let it be. Let's give you the respect that you deserve. Okay, that's fine. That's fine. All right. So me, I want to say that you know, medically, we are beginning to overlook what the traditional medicine can do for us. And it doesn't matter how long you've stayed in the US, you agree with me that until recently, the prevalence of cancer, whatever form, was not as high as we're seeing it now. And I know that growing up, we were told that when you eat a lot of tinned tomatoes, that is processed tomatoes, you can get cancer. You eat a lot of sardines, you can get cancer. You know, that is what we knew growing up. Where is the role of traditional medicine and practice in the care and treatment prevention of cancer?
That's a very interesting question. One, I will first of all agree with you that almost all cancer specialists around the world agree that having overprocessed foods has increased the risk of cancer, especially colorectal cancer. Some people, they will not eat those tinned tomatoes. I will tell you, A good example is Florida. The man likes to eat natural foods. He grows his own tomatoes and all of that. But I try to grow mine too. So more people who are really health conscious, they go to farmers market, they get their foods there to reduce the ingestion of a processed food. So I think that's a very recognized risk factors the world over. Traditional medicine, I am of the opinion that we as Africans, we have neglected our cures because of, we have this debate in our general forum of what colonization did to us. It took away the belief in ourselves. And so we would rather go take aspirin when I will tell you, my uncle growing up, there is a herb. I wish when I come next time, I may find a way to sneak it in. There was a herb that we will go cut, you rub on the head, your headache goes almost instantly. It's better than any medicine that I've ever studied since I went to medical school. But if I came and gave that to you, you were like, no, I want to get the aspirin from Bayer, from Germany. So we, now our generation, we need to find ways to rediscover our own medicine. Most of, and this may come to you as a surprise, most of the chemotherapy drugs that we use, if you ask me how they work, we don't even know the mechanism. We just know that they work. That's exactly how our traditional medicines work. We know that they work. If you ask how they work, we cannot explain how they work, but they work because over the years, our forefathers tried them and saw that they work. What we should be doing, including people like you who work at universities, is documenting these things, cataloging them, identifying the people who do the treatments so that we can now go, if you go to the cancer center in Bingo or to the one in Yaoundé, you pull that medicine off and you give to people. Then going to a point where you standardize the dosing. That is how all of this works. I treat childhood cancer. We started out in the 1950s. We would sometimes treat for 6 months. We thought we were done. Then we saw it will come back. So we fine-tuned the protocol until now we have the standard protocols. So it's really up to us, Africans, I would just say, to standardize our medicines. It works. That's what kept us. But our cancers are increasing. One, we are not using those medicines, but two, our lifestyle. We are changing the lifestyles to the Western lifestyles. And that we are getting, when I was a medical student, they used to say, oh, you go and treat malaria and diarrhea illnesses. You don't need to worry about cancer. The cancer is very much an issue now in most African countries.
Thank you, Dr. Beng. Tekla, your hand is up.
Yes, and Joan, I still want to ask Dr. Beng, because I didn't hear him talk about pesticides. Before, in Cameroon, or let me say in Africa, people will just plant their njama, they will plant everything. They won't use pesticides, they won't use fertilizer and so on. And we can see that before this cancer was not as prevalent as now. So can you a little bit tell us about the effect or the impact of pesticides and the fertilizer that they are using now on our lives?
Yeah, so I will tell you, I just put that all under the rubric of carcinogens, right? All those things that you are in an environment that increase our risk of cancer. So pesticides are clearly one of those things that increases the risk of cancer. I can tell you there is a big, what we call in the United States, class action lawsuit against a company which uses a weed killer called Roundup. You guys probably use it in Cameroon too, because it has been shown that it causes a type of cancer called lymphoma and other types of cancer. So a lot of people who take care of lawns and they spread this a lot of them end up with cancer. I can tell you that about 5 years ago, I was or to testify about occurrence of cancer in children in one of the U.S. military bases here because of some of the waste that they use in the military base. And there were these children who were born there. And 1 year, there were children who were born in the same week. 5 of them developed the same type of cancer. So 2 of them were treated here at our center. So we have to suspect that there was something in the environment there. So it's not just in places like Cameroon and the rest that is an issue. A lot of these pesticides have been linked to cancer. Many more of them are being banned in the United States and Europe. Unfortunately, some of those banned pesticides here are shipped to places like Cameroon, where they are used because there is not enough government regulation, or even where there is regulation, people are able to bribe their way through to still using them. So I would say if you are a farmer or if you do that, you should be very careful. I think one good place to go is the United States Environmental Agency. They will have a list of some of those banned pesticides. Just look at the research on that and see if they have those agents, and you may want to avoid. It's not just that they get into your food chain, is that when you are handling them, they get through your skin and they can be carcinogenous, or they can increase your risk of cancer, but they can also cause other problems. They can cause growth problems in children. They can damage organs and cause things like diabetes. So I do agree with you, absolutely. The pesticides and other environmental toxins are causing a big damage to us all over the world. But unfortunately, to feed the growing population, some of these things are there to stay. I will stick with practicing medicine, but I am a big critic of all these chemicals that we use in our livestock and other agricultural aspects.
Okay, Collins.
Okay, thank you once more, Joanna. Thank you, Doc, for spending your time. I want to go back to something that Joanne brought up about traditional medicine and stuff. I give an example of myself. I went to my primary care. I think for a while I was having problems with gout, and he had all these cocktails he wanted to start me with. So I kept refusing. I mean, I was in pain like almost every day. Each day I go to a party and come back, boy, for the next 1 week, I'm suffering hell. But, so there was something I was trying at home, and I told him like, hey, this is what I'm trying. And the first question is like, do you know how it works? So my point is, for somebody like you who knows some of these drugs that work, is there a way you could come out with a consortium or something who can work with phytochemists and pharmacologists back home to try to look into that? I know drug development and research is kind of expensive, but is there some way you can set up something like that?
So I would tell you, I actually have a good friend, Kabanubia. He's now in one of those drug development companies, but he had actually started a project like that in Cameroon, trying to identify this. Because I will be honest with you, if we become more organized and you have something like that, right? If you purified it, the pharma industry could pay you a lot of money to buy over the patent for that. I always tell people a lot of what is manufactured by Bayer or Pfizer starts out as a traditional medicine or some herb that people use. So my problem with that, and I will tell you, let me just give you a good example. When it comes to cancer treatment, people use a lot of what we call complementary medicine. So that's medicine that is outside what you go get from the pharmacy, or what we say is on the protocol. I generally don't tell people not to use it. I tell people to bring the name to me if it's something that has a name. We frequently can then cross-reference to make sure that it does not interact adversely Because if that medication is working for gout, you have to assume that it has a metabolic effect. Gout is basically a build-up of uric acid. So it has an effect on that. So when you take it, there's a chance that it may interact with other medicines that you are taking, and then it could potentiate the side effects. And I think that's a problem that people frequently have, that you are taking something else, I give you something on top of that, then I do not know what side effects to expect and how it's going to influence the side effects of what I'm already giving you.
Yeah.
So I think our generation and the generation coming after us is really up to us, that when we have something like that, how do we collect data on it so we know, do you drink 1 cup a day? Do you drink it 3 times a day and you get the effect, or do you just drink a gallon of it? And that is something that the authorities in Cameroon need to do better. My hope is now that we have 5 medical schools, if I'm not mistaken, in Cameroon, that is a research that people do. I myself, I'm getting to the age now that I'm trying to see ventures of how I can collaborate with some university in Cameroon. My research interest is sickle cell disease, really not drug development. But if you have people who have very serious interests, you know people who are focused in drug development. I do clinical trials, but I am not the one who develops the drugs myself. But we do have some very potent compounds, which honestly, if you purify it, you could sell it to the big pharma at a very good price for yourself. Big pharma is always out there looking for what works. I can tell you they can't find it, they work, they may not even tell you that it worked, they will just figure out where you got it, and then they go purify it, and they call it the blue pill.
Yeah, I know.
It's
like one of the biggest university systems in Texas right now, UT, is working on bitter leaf. All of a sudden, it's just a big deal. Yeah.
When I was a fellow, we actually worked on, there's this special soybean in China that has been shown to inhibit cancer. So there was this guy, he's a Chinese, but he has snuck that in from some Chinese medical doctor, and we basically extracted the product and we were testing on cancer cells.
My whole backyard now is bitter leaf. I hope it gives me some, it's giving some money. Oh my, that's good though.
Okay.
But I can tell you that the medical research is so decentralized now, and I really hope that all the young people that we are sending through medical school in places like Bamenda, Buea, Yaoundé, that they start doing some of this research on our things, because the ones that have worked, we don't know if the Pfizer Viagra was stolen from Cameroon, right? Nobody knows. So some of these people come, you think that, I quite remember my father, he used to have his medicine thingy.
Are you talking about
Vita-Cola? Would come and be asking.
No, it's the Yambe tree.
Are you talking about Vita-Cola?
No, it's a tree back. The tree back.
Where could he's talking about bitter leaf, but Vita-Cola may be Viagra, who knows, right?
It's 4 a.m. It's 4 o'clock. Take Vita-Cola 4 o'clock, you act better than you are. I'm just telling you, no Tifamo. Just know that I told you. I think
I should be looking for grandkids.
You say
I know be you.
Now wait. I say I will never reach a stage where we fear 4 a.m. We not the fear 4 a.m. yet. 4
a.m. I didn't say wake up run. You tell me say my kid now.
No, lie. You must finish that work. Wow. Okay. Now Peter and Evelyn, who came first? I don't even know who came first. Okay, Peter, your mic is open, so you can ask your question. And then after Peter, Evelyn.
Yeah, Doctor, thank you so much for the brilliant presentation. My question is simple. What would be your advice to someone who has just been diagnosed of cancer?
It's a very scary diagnosis. What my advice is, one, not all cancers are not the same. I think we talk about cancer here as if it is one diagnosis. Most cancers are actually very curable. Unfortunately, there are some cancers that we have very little to offer or little to do about it. So if you're diagnosed with cancer, yes, there's going to be shock at the beginning. You want to talk to your loved ones, take some time, reflect about it, and sit down with your doctor and discuss what type of cancer it is. If you are living in a country which has a comprehensive cancer management program, consult a comprehensive cancer center and sit down and talk to all the specialists involved, what the treatment will be. I will tell you, in the United States or most of Europe, there are standardized protocols. So it does not really matter where you go. If you have a certain type of cancer, you will get a treatment which it will be necessary for that cancer. If it is a cancer that they tell you it is curable, ask what are the side effects, and go for the treatment. Do not do half treatment. Some people get scared. They're like, okay, I will do half treatment. Even, there are some places where you have to pay for it, and people say, okay, I will pay for this, I will not do this. You cannot treat cancer halfway. Then you just give it a chance to develop resistance and cause more problems. Again, fear will be up there, but don't go in with fear. We know that if you go in with hope and you go with a positive attitude, you have a higher chance of getting a cure. If you do not trust your doctor, look for a different doctor. If you have the option somewhere, some places you don't have an option, but when you sit across your doctor, they're talking to you. If they don't inspire confidence, ask for a different doctor. In most places, you have that choice. If it is a type of cancer, so I will give you an example, breast cancer, most breast cancers are very curable. Some of them you cure with surgery only. Some you may end up needing chemotherapy and radiation therapy. But most breast cancers will be curable. Most prostate cancers will be curable. Most colon cancers will be curable. Now, leukemias, most of them are curable, and you are going to be done with it, and you are going to move on with your life. There are some brain cancers that there is not much you can do about it. So there are some of those cancers, they will tell you this is it, and there's almost nothing available. And I think some of those you want to take a deep breath about it. Some you may just need to consider what we call palliative care, which means you try to get a good quality of life with your family members. But most cancers, you have very good cure rates on it. So cancer is not one disease, and the mistake people frequently make is to assume that, oh, it's cancer. I have cancer, I know this person who had cancer and they did not do well, so I'm going to be just like them. No, your cancer is likely very different from the cancer of somebody you knew. Even breast cancer for one person may not be the same type of breast cancer the other person has. So I mentioned breast cancer. Breast cancer is not the same. They are all different types of breast cancer. Colon cancer, they will be different. So don't say, oh, I have breast cancer, that person has breast cancer, so mine is going to be the same now.
Thank you,
Okay,
Evelyn.
thank you.
Myself. Okay, I'm back. Yeah, I just wanted you to throw more light on cervical cancer as per a case in Cameroon. What will you advise how people should go about getting themselves screened and all that? Just a kind of informational message.
So I think that cervical cancer is unfortunately very common in Cameroon, as we saw. It's the third most common type of cancer in Cameroon for multiple reasons that we can discuss. So I do think that one, for those who have the access and I hope most of us on a forum like this have the access, you should get routine cervical cancer screening. These ones are very easy speculum examinations. I say this because my sister in Cameroon, she does get hers done routinely by her gynecologist in Yaoundé. So you go, they do an inspection, and they can do a visual inspection. Several gynecologists in Yaoundé and Douala, they will even do the pap smear, which is more routine here. So I would say you can afford it, you should do it. If you live somewhere where you do not have access to gynecology, or you cannot afford to see a gynecologist routinely, I will say if you have abnormal discharge, if you have pain during sex, you should go have at least a speculum examination so that they can visualize. Because it's really important that that's caught early. Again, several centers, not just Yaoundé, places like Bingo, even Bamenda and the rest, you could go and you have precancerous lesion, even if they do not clearly delineate, they can basically scrape off those precancerous lesions, which can eventually become cervical cancer and spread. And you get to a point where you may need to get hysterectomy or much more aggressive surgery. So that visualization is really important. But unfortunately, most of Cameroon, people are not going to have access, be it for financial reason or be it because they don't have this health facilities to do it and they end up with lead disease. But you probably know a little more than I do, Evelyn. Why don't you complement or add more what people should do?
Well, yeah, you said it all. It's a matter of getting informed and knowing that this is actually something that is curable, and we need to get ourselves screened routinely, and you start off at least during the early 20s. Well, here you will want to get the kids as much as when they get into adolescence, and you start giving them all the vaccines that are required. But I don't know how it is in a case of Cameroon, whether those vaccines are readily available, and whether people are actually aware of it. And if not, you miss those steps that you should have given them those vaccines. And then it is important that we know that we get ourselves routinely screened for this very deadly but preventable cancer, such that if it is diagnosed early enough, then it is taken care of and you are 100% cured. But if you allow it to kind of diverse and get into other tissues, especially tissues that are around, organs that are around the cervix, that like it can go to your kidneys, it can go to infiltrate into the uterus, then it becomes something very complicated. So early presentation and getting yourself adequately screened routinely, you can really save many lives. Well, that's just the message. So creating that awareness in Cameroon is very, very important, because here you go to the hospitals, normally you have those reminders, but I'm just wondering what it is in a setting back there. So those of us that are there should, if you have a relative, make sure that they get this information so that you can save a life.
Thank you for that. I would just add that the HPV vaccine is available in Cameroon, but it's not part of the immunization, the national immunization program. It costs about 45,000, the 2 or 3 shot series. That's, I don't know how many families are willing to fork out 100,000 for vaccines. But I do think that some of us here, if you can, you should get that done. There have been pilot programs sponsored by UNICEF. Unfortunately, some of them have not gone so well because parents have resisted it. But that stock is gone now. If you want to give the HPV vaccine, unfortunately, you have to pay for it. The government is looking at sponsors of funding agencies to see if they can incorporate that, but currently it is not, at least based on the information that I reviewed last week.
Wow.
All right. Evelyn, thank you very much. You see, you've just thrown more light into all of this, and it's just so nice to know that we have all these talents and intelligence and all that we can think about in this group. I want to ask a question. There is this issue about sex. That is to say, ladies who have had kids and who for some reason have had tears that have not been well handled, or they have probably done the thing so much that the elasticity of their vagina is loose. And so they start introducing stuff to tighten that place. Does that have an effect on cervical cancer?
So there is not, and people can feel free to chime in here. There is not much body of evidence that has studied that. So as someone who bases discussion on data, there's no data on that. But what I can say is that especially cervical cancer, we know that a lot of it is inflammation driven. That's why we will see it more in people who have HPV. So you induce this, and then so you have higher rate of inflammation, you have a higher risk of what we call malignant transformation. So I would caution anybody who does that, because when you start introducing these substances, especially if they do have the physical and chemical properties to tighten, as you would say, which is basically constriction, that means it's almost a form of scarring that's happening, and that is inflammation. So I think there is at least a theoretical risk that it will increase your risk of cancer. I don't know if other people have comments on it, but there is no research on it.
This alum that people are putting to tighten that place has no negative effect. I should not advise those young Moliko girls, because Frungang is in trouble. I should not advise those young Moliko girls to stop using the alum that they are using.
Then tell them to stop it immediately.
Well, I should think that anything that is constantly irritating tissues has the tendency to trigger those tissues to undergo certain changes. Okay. So why go to something that is not natural? Allow the body to take care of that environment. When you constantly have those kind of things inserted into the vagina or right there up into the cervix, then there is that tendency that over time, long irritation will cause those cells to start going malignant, because that is how cancer comes about. So even though maybe there might not be research that has been done based on that, just thinking about it, irritants, you don't want to irritate an environment longer than necessary. So I should think those individuals will be more predisposed to, say, vaginal cancers, because it's along that pathway getting all the way to the cervix. And then why not the cervix? It's an irritant. Though we have the human papillomavirus as the main trigger to alter those cells there to start going into a malignant transformation. So my advice, don't have anything there that is not necessary. And besides, with the healing, that has been caused, because those irritants will cause inflammation, and then there will be healing, and there will be constriction, such that they, over time, will eventually be having dyspareunia. They will be having issues when they want to have intercourse. Because that area will become constricted. It has healed, and then it has reduced the size instead. So I don't know how those inserts, they help such individuals.
Evelyn,
I would just say that my sister Joan, as their mother, since you are also their mother, though you are their teacher, that's just advice. If you come across any of them, tell them that what they're doing now, they're just hurting themselves 15, 20 years down the road, are not going to enjoy sexual intercourse, and their partners may not enjoy it, but also they may really get into some serious health issues. These are problems of youth, and it's difficult, but I am also a teacher. I do sometimes find myself just trying to advise young people that these things that you are doing, you are going to pay a price for it down the road. Just try not to do it. If they listen, it's another thing, right?
Right. Okay. I wanted to just follow up with what Evelyn said, because I wanted her to, being a woman as well. And okay, we've talked about the younger ones. This is us at this age, 50. Ladies have been entering menopause and stuff. And you know that one of the side effects of menopause is dryness. So sex becomes an issue. And so Evelyn, do you mean that if I don't do the proper lubrication and I keep doing that thing, I will end up having some cervical cancer or something? Both of you should just enlighten me so that I will know that I will be wearing corset and sleeping with it now rather than just
if I be careful with that answer.
Well, I'll be looking at it in the point of the fact that, yeah, you're using that thing because maybe, but why should they use it anyway? I just want to, how does it, is it an antiseptic? Do you anticipate it to have an antiseptic value, or it is something that, because if you use that, the consequences are that.
Evelyn, this nyamangorona, you know what they use to wash nyamangorona?
Okay.
They use, yes, that is what they're using. That is what they're using. But actually, I was asking now about us at this age.
Right.
If we are not in menopause, we are getting into menopause, or some are fully in menopause. And one of the effects of menopause is dryness. And dryness makes sexual intercourse a problem. And there's a difficulty if you had to talk about lubrication that you talked about. So what I'm trying to find out is it then advisable to reduce the amount of sex you get as you get older because of this dryness, and that can eventually lead to cervical cancer, or what? I just wanted us to clarify this a little bit.
No, you should not. You should not, because no use becomes disused, and you have that area will become.
Good answer, Emily.
I can fire on.
Yes, of course.
All right,
yes.
all right. Thank you, my sister. Thank you.
Please, when you leave it, it becomes atrophied, and then it becomes useless. And then you find it very difficult to even get it back to normal. So, the frequency.
Now, I just want to clarify, Evelyn was talking about these irritants that you put that induce inflammation. I think it was not generally that the friction that comes from dryness during intercourse, that itself is not going to cause cancer. This is a big problem. I think that people don't talk about it. I think couples should talk more about it and buy the lubricant so that it's pleasurizing for everybody. I do think at our ages, you don't get to 50 and you suddenly don't have to take pleasure in these things. If we want marriages to continue, especially, I will speak as a man, you don't want your man to be going to Moliko. You want to get that lubricant so that he's not going to Moliko.
That's true. That's true. But you know, Evelyn, we should not release the cat. There are some lubricants that will pay us before we tell them. Don't mind them.
Okay, yeah.
Any
There's a
other
female
question?
section on Walmart, Joanne.
Eh?
There's a female section in Walmart.
There's a female section. You did Walmart, you did America, me I did America. See me the man.
There's no Walmart in Moliko.
There's a Walmart in Moliko. It might just have a different name. Anyway,
No,
I want to come back to what you were saying, Joanne, about the alum that you were saying. If alum is used in cleaning snails and takes the slime out of it, don't that actually mean that the alum takes out the lubrication from the vagina and stuff and makes sex less pleasurable for these girls? And in addition to all the diseases that it does, because I don't see how it actually help in I don't know what their purpose is, but I think from what Evelyn was saying, they cause inflammation, and Dr. Beng was saying it will cause inflammation and atrophy and scarring and all that stuff. So I don't know if they actually find that.
Collins, what is happening is that, you know, when you go to salons, you hear a lot. When you sit down with those kids in the salon, you hear a lot. So the problem is that their vaginas have become so loose to the point that the men are complaining that they are swimming in them. So to tighten it is to use alum. Some have used alum, some have said they've used alum, and some even have a liquid that they're selling or something that they're selling. Some have even, exactly. So the reason why they use alum is because immediately you put alum in snails, you see that it shrinks. You see that the snail shrinks. The body of the snail shrinks.
So the muscles kind of constrict.
The muscles kind of constrain. So it tightens the place for them, and then you guys can enjoy it better. So my point was, is it advisable to continue to advise them to do that? And you know, when we sit in salons, we listen to a lot of things, and we hear these children talk. Sometimes you don't just want to start talking because it's not your place, you know. It's not your place, and a child can just
in that instance. Yeah, I understand.
Yeah. So, but I have girls, and I need to be able to start talking to them and to advise them. That is my role as their mother. And this information that I have now, I think it's very educative for me as a mother of girls. And if I sit in salons for those who want to hear, we might just get into that discussion.
Yes, I hear you.
So the reason is really not because they don't want the sliminess, because if you want the sliminess, it doesn't satisfy them, or it doesn't satisfy the man, and so they don't get the money. That's the truth.
Now I get it.
Yeah, that's the truth.
But I'm not a woman.
And that is why the girls who are older, find out that the younger girls are taking over their men because you know so it's a whole draft that you have to look at.
You're so quiet. It looks like you don't have anything to say.
Who is that?
Yeah, I have a question, since it looks like the discussion is going sideways.
Bring it back to the middle.
It's going to Joanne's topic.
No. I mean, these are important things, and people should. I'm just trying to make a joke. So, Beng, great presentation, great talk. Can you please go to one of your slides there where you actually presented the data? It should be slide number 8 or 9, or the data for Cameroon. It was, yeah, right there. So here we are, like you said that is this a GTZ study, or where is this data from?
So this data, I don't know where they got the data from. They say DHS, I don't know exactly what it is, but this is in a 96-page report from the Ministry of Health in Cameroon, looking at the state of cancer care in Cameroon.
Yeah, this is really misleading data, right? Because I'm sure this is misleading data.
It's very misleading, yes.
I don't see how the Northwest, I don't know any chemical things, or let's say if there were some, stuff going on in the Northwest region that would, would make the population of Cameroon, the population of the Northwest region is about no more than 10% of the population of Cameroon, right? And then if you are having at least twice as much the cancer in Cameroon than any place else, there must be, like you said, when you see two children born around the same time having the same kind of cancer, you know that there is an environmental issue, right? We can't really say that there is an environmental issue. I know that you mentioned that there was some study by GTZ, right? Is it? Regarding regarding collecting data for cancer?
Mm-hmm.
And was it only done in the Northwest region or somewhere else?
So, Charles, I will just give you a little insight. So, at least in my impression, until before the war, yes, the Northwest had one of the best organized healthcare system in Cameroon. So I know, for example, when the GTZ, when they wanted to pilot how do you do primary care in Africa, the Northwest was actually what they picked. I say this because I met some of the authorities. So most regions did not really have this district health system, and where you had this pharmacy system. So they picked it, and when you pick it as you're implementing it, you are able to collect data. I can tell you that also based on the fact, as I mentioned, Bingo Baptist Hospital before the war was actually, of all Cameroon, the most comprehensive place for cancer care. It could be that all of this data is just from Bingo Baptist Hospital, right? And if you don't have anywhere else in the country that are collecting this data, they're going to look as if there is more cancer there than other places. Mm-hmm. That's why instead of saying what is in the Northwest is abnormal, it's more likely that the other places are the ones which are a false picture. Because I can tell you, most 90% of the people who have cancer in womb, they do not even know that they have cancer.
I would like to throw more light into statistics in Cameroon. We are very bad in keeping statistics about anything at all. So this is not surprising, and we are in a situation where if a foreign body who is funding a research study stands up one day and says, okay, please, can I have statistics on this? People just fill in figures and without really giving the real value of what is happening. So this may be what is happening. I'll give you an example. The other day, last 2 weeks, we had cholera in Limbe. And you see, everybody is giving their own statistics. Oh, 100 people have died, 70 people have died, 45 people have died, this. Nobody is giving you a comprehensive statistics so that, and they don't know that misleading statistics gives a lot of problem in planning, in even governance as a whole. So Charles, this could be misleading from two sides. It could be misleading from two sides. It could be misleading from the collectors in the Northwest, and it could also be misleading from the other regions that they didn't collect any data at all. So I'm sure that Beng will just put the data as it is, but he cannot vouch for the figures that he's seeing there. Neither can he explain why the figures are the way they are. Yeah. But all I know is that cancer is increasing in Cameroon, whether we have the statistics or not. I mean, when you hear from the relations that you have and all the other stories that you hear, you don't understand that it's on the increase. It may not be as alarming, or it may not be at the rate, but I think that we really, really do have a problem with statistics. We have a problem with statistics.
Yes, and again, just to be clear, I was not trying to impugn anything that Dr. Beng said. because he actually gave a caveat, you know, that it might just be that GTZ collect. That's how I got to know that GTZ even work in Cameroon. So I'm just trying to highlight the point that that you are actually highlighting, that where we don't have a way of really knowing the actual data for these things, and some of it could be politically motivated for something, for, you know, and stuff like that, or to inflate the data in order to get a grant, or to deflate it in order to, you know. So yeah, the second part of what I wanted to comment, or not comment, but make you talk a little bit more. What's the influence of secondhand smoke? Because that's one of the causes that you said, smoking and all those. But I do know, at least here, that secondhand smoke is considered as much as dangerous as the actual primary person smoking.
I think you've stated the fact, right? So that's really one thing that is still happening. I'm not sure how true it is, but when you read the report by the minister, he states that smoking rates are continuing to increase in Cameroon. And it goes on to state that about 15% of the people are primary smokers and 40% are exposed to secondhand smoke. And as you know, data from the 1990s, 80s and 1990s showed that you who are not smoking, but just sitting around others smoking, you are just as being damaged as those who are smoking. And that's why all the regulation that we have here, that you cannot go into a restaurant and smoke. You cannot, you have to go stand 500 yards away from a building to smoke, and so you don't make other people inhale. You want to poison yourself, you do it to yourself and leave the others out of it. So if it is true that in Cameroon, the rates of smoking are still increasing, that is a problem. But again, the minister himself says that the rates of smoking are still increasing. I'm surprised that's the case, because I thought smoking has become so ostracized that throughout the world, less people will be smoking. But that is a big problem, and it's really up to the regulatory authorities in Cameroon and other places where there's still a high level of smoking, that they regulate it, at least protect those who do not want to smoke from those who want to smoke, so we are not smoking involuntarily.
Yeah. Collins wants to take us sideways again. Okay, let's have him.
I didn't do that.
Now I know there's something. Did you call it was alum, right? It's called alum.
Alum.
No, Charles, I was coming back to your question. I didn't get all of it because I got a call and I tried to talk about it. Well, looking at that same data, right? Yeah. If we realize that, I think where we seem to have more medical care, there seem to be higher reporting, right? And then from what the doc said was that Bamenda was actually a pilot program. So I think that maybe the data there seems to be skewed because there was more accurate reporting or more data collected from what I'm seeing, or maybe I'm making a mistake. I didn't get all of the discussion, but I think that's what I gathered.
Yeah. I'm in agreement with him. And like I said, he put a caveat there. I mean, when what attracted me to is when I look at data. You know, I've been trained to look at data in a certain way. You know, so that catches my eye and stuff like that. You know, so one of those things they say correlation does not equal causation. You know, so I mean, everybody knows what I've said. So.
Okay. Yeah, because if you look at the areas where there's hardly any medical facilities, you barely have anything, like South Province.
Exactly. Look, just when you just take a look at the data. Okay. Look at Southwest.
Yeah.
What is the difference between people living in the Southwest and people living in the Northwest? And they are like a fifth in terms of, you know, percentage of. So for every 5 people in the Northwest, you have one having cancer, you have just one person in the Southwest. That's not that it doesn't just.
I think it's a reporting, but
Yeah,
at a certain point,
or the collection actually.
The collection. At a certain point, I was really surprised too by not this data, but maybe about 5 years back. All of a sudden, everybody who died was of cancer. They stopped reporting acute malaria and acute typhoid. So I was kind of concerned. I thought maybe some of the doctors were playing mago-mago and wanted to make more money. Because
no, Collins, the thing is, what is happening in Cameroon is that we have reached a stage where everybody wants to make money. And so they put emphasis on things that they know. If there was a project that had to come with a lot of money on cancer, let's say, all of a sudden the emphasis will be in that line.
Okay.
And I think the trend is not only Cameroon, the trend is all over the world, because if you look at it carefully, people are not talking much about COVID anymore. You see, and he had to take Boris Johnson to take a bold step to say, okay, we're not doing any lockdowns anymore. And even after he said that, we're not hearing any more deaths, you know. And so it's a trend that is going all over the world, that everything is politicized. Everything is politicized. And the politics also goes with the financing, you know. So that kind of thing, that is what I'm seeing here, because you cannot tell me that Bamenda will have more cancer patients than Littoral and Center region. I mean, this is where the population is, no matter what.
Exactly, and I actually misspoke, because when you look at the data, it's 10. There is more prevalence of, there's 10 times more prevalence of cancer in the Northwest than in the Southwest. I mean, that would basically be something that is eye-popping. We would have known, you know, anecdotally, you know, not that, you know, somebody's, you know, anyways.
So I think that as the data was there for information, and he just used it for his presentation, we shouldn't take this data for what it is. We should just put question marks and then just know that there is something that is called cancer, and we need to be careful about it, and we need to let our loved ones know. And we need to refuse, we need to tell them not to use alum. Please tell your girls so they should not use it.
But I just like to mention here that we say this is the way it is, right? I think I commented before in the general forum. We are the ones, our generation is the one that runs the world. So I think when we see things like this, that this is bad data, it should all make us worried, because if somebody comes to Cameroon, or the Cameroon government should be using this data to inform policy. So if you are making up data, you have false data, then you are hurting the population. And it's not some magical person. It's, again, we in our late 40s, early 50s, we run the world. It's not somebody else. And you, John, you are at a university. I do think universities are the places which produce data, or should really be pushing on how these things happen. And it's just unfortunate that you have, and I agree, this data is useless. It could be, you could put the bars wherever you want to put it, they will be there. If this was true, then the Cameroon government should be investigating the Northwest region. What is happening there? They should be bringing in radiation experts to come and
find out what's going on.
to see what's going on. So yes, I don't think anybody takes this seriously. The minister himself, I don't think he takes it seriously. But I hope the University of Bamenda takes it seriously and investigates.
Yeah, there was some other data, let me not say data, at least about maybe 7 years ago, some French guy in Cameroon told me that the Northwest region has the highest cases of HIV and stuff like that. But I mean, it could also be just things that people talk about for political reasons and all that. Then also, the Northwest region was going through some political stuff which was not favorable to France. So a French guy is telling me that. So it could be that he heard that as part of, their propaganda for whatever reason. But I would have expected that there would be more deaths from then of HIV or, of AIDS from Bamenda than everywhere else. But I don't see that, in reality being the case. So some of these things.
I had had this experience before. We had an international conference in Yaoundé on cyber crimes, and a commissioner of police in Cameroon stood up and said, University of Buea is the hub of cyber criminality in Cameroon. I flipped and I asked him, I said, how do you get your sample size? What makes you make this kind of passing statement to an international audience? You stigmatize
the whole university, yeah.
You stigmatize a whole university on information that you don't even have. I said, what research did you conduct to come to that conclusion? And it got to a point where he had to apologize to the University of Buea, because this is what happens. Because you are excited. I don't know whether it's excitement, or I don't know whether it's for financial reason. I don't know whether it's for political reason. You just make a statement. You just say the Northwest region is this, or the Southwest region is this, or University of Buea is this. We that's the role we play as educators and as researchers, just to say that, we have to be very careful when we put data out. You have to be able to substantiate and support the data that you put out, because you could be called upon to defend that data. Because if we take this thing like this and we put it up, somebody can be asking you a question, and thank God you took it from the Ministry of Health. So it's not something that you cooked up. It's not something that they can run away from. What parameters did they take? What explanation? Because sometimes you see it like this, you give an explanation. What explanation did they have for it? So I think we should, it looks like all the women and the men with breasts, the women in the Northwest and in the Northwest region, their own breasts, their own cervix, their own prostate are such that, every single, in every 1,000, you have about 500-700 who are suffering from this. I mean, this is not fair. This is not fair. But again, for the purposes of our talk this evening, we must understand that it exists, whether the numbers are correct or not. It exists.
What I would just want to add here is that when I hear this, I am one disease. People should really not be worried about disease stigmatization. It's not like you go, especially cancer, you don't go ask for it, you don't beg for it. I still believe that up to the time that the war started, including the HIV program, the most efficient one was in the Northwest. For example, I know the HIV coordinator who was working at the district hospital in Womb. They had a registrar. When you come, you get your medication. They were really putting true data in there. I went there once and actually saw that. They could actually tell you the addresses of all the people who were getting medication. So this fits exactly the same HIV data you guys are talking about. Came out. I'm like, so this fits almost that pattern that there are some places where they keep the data better. And you look at the Northwest, you had the Shisong Hospital, you had Bingo, you had even the Bamen. So there are just more reputable health institutions in the Northwest, or they used to be, than elsewhere in the country.
All right, you're right. You're right. So I think we've had more than 2 hours.
Really?
Yep. We've done quite some justice to this first topic, and I'm very, very, very proud of you, Dr. Beng. I'm proud of everybody that was able to attend. I thank you guys very much. Charles, thank you very much for co-hosting this thing. I have gone through YouTube and I haven't had any questions. The watch was not too much, but I think things will get improved as we move on with more topics and more things that we want to discuss to help ourselves and to help our kids, help our families and our loved ones. So I think it's fair to say that we can close here and take the rendezvous for another day and another topic. And hopefully people will get interested and people will join us. This is a reality. We can't run away from it. I said, this man, thank you plenty. This book where you go to not be small book. Oh, that was very good. In fact,
if now you don't talk, no. Me said that fine where you be charged me, I never pay the fine again, no.
No fine, no fine. You give that look like man boy, no fine, no fine, no fine. Thank you very much, Dr. Beng. Thank you very much. God bless you all, and hopefully we'll meet again. Thanks.